Yeah. Shall we start the interview? Okay.
Yes, please.
As an expert in mitral and tricuspid valve treatment, would you please share us the current international research status of the mitral and tricuspid valve intervention?
Of course, thank you. It's my honor to participate in this interview, particularly for many of my colleagues and friends in China. The mitral valve, and I'll talk about tricuspid valve next, the mitral valve for the long time has been the mainstay of our surgical colleagues' armamentarium in terms of when patients have significant mitral regurgitation. Open mitral valve surgery to repair, or even in some cases to replace, has been the primary procedure to be done. However, of late, we've been doing a lot of research, clinical trials, how to repair or even replace the mitral valve from a less invasive transcatheter approach. The first therapy studied was something called the mitral clip, in which we didn't need to make any incisions in the patient's chest. It was delivered from a transvenous, transeptal approach, so a femoral venous insertion point. And then we were able to place this device, a mitral clip, on the regurgitant leaflets of the mitral valve, affecting a repair. We initially studied that in the Everest 2 trials, which showed that in very high-risk patients, we had a benefit because it was a very safe procedure. It may not reduce the leakage, the mitral regurgitation, to the same degree as open surgery does, but in the hands of a very competent operator, and for a patient who is high risk for open heart surgery, this is where it really shined. We next studied it in the COAPT trial, which took patients that have mitral valve regurgitation secondary to cardiomyopathic state, a weak heart muscle. And in those patients, we've known that open heart surgery has never been shown to improve their survival or keep them out of the hospital. And in the COAPT trial, we showed for those patients that were already on guideline-directed medical therapy for their heart failure, that the addition of doing a mitral clip significantly improved their survival, their symptoms, and their ability to live a healthier, productive life out of the hospital. And for that, we have a lot of excitement for doing transcatheter mitral valve repair. Unfortunately, we know that there are some types of mitral valve disease where doing a repair procedure, like with a mitral clip or similar device, is not going to work because of the complexity of their valve leakage, or that there may be a benefit for more complete elimination of the mitral regurgitation, and this all comes from replacing the valve. So we have a number of clinical trials that are currently in progress right now about how to replace the regurgitant mitral valve, all via a catheter. The initial ones were done from a transapical approach, and now we're studying doing it from a transfemoral venous approach as well. Many of these same technologies, these same concepts that we've been applying and studying in the mitral valve, we're now shifting to learn how do we use it for the regurgitant tricuspid valve. One of the challenges with the regurgitant tricuspid valve is it's intimately connected with the right ventricle of the heart, and therefore may be associated with a lot of right ventricular dysfunction. And we're having to learn who are the right patients to do this in or who not to. Either way, these repair and replacement technologies, again, are all delivered from a femoral venous approach, a percutaneous and very less invasive approach. So I think right now, in this current era, it's very exciting, some of these new technologies to, from a less invasive way, repair or replace the regurgitant mitral or tricuspid valve.
And as we know, there have been many trials on the transcatheter interventional therapy of the mitral valve. What is your opinion about the different results of those trials? What are the challenges in this clinical treatment?
So I think the most important challenge is understanding the appropriate patient selection. Who are the right patients for a given transcatheter therapy? I'll take the example of the COAPT trial and the MITRA FR trial. In both cases, we studied patients with what we call secondary or functional mitral regurgitation. In those patients, as I said previously, they have a significant degree of leakage from the mitral valve that is due to an underlying weak left ventricle or cardiomyopathy of the left ventricle. But there can be a spectrum. Some patients can have more mitral regurgitation and not as weak left ventricle, and other patients can have a greater degree of cardiomyopathy or greater degree of weakness of their left ventricle and lesser degrees of mitral regurgitation. And which of those patients we should or should not be treating had not been entirely clear in the past until we did two relatively large randomized clinical trials. One was a MITRA-FR trial out of France. There they tended to study patients that have worse left ventricles and not quite as bad mitral regurgitation. We also, it wasn't quite clear whether they were on optimal guideline-directed medical therapy. But in that group of patients, treatment with a percutaneous approach like the MitraClip did not meet the primary endpoint of the study. On the other hand, around the same time, we did another large randomized clinical trial, the COAPT trial. And in those patients, clearly they were failing guideline-directed medical therapy. They had more severe degrees of mitral regurgitation, and their left ventricles were less severely affected. And in that grouping of patients, intervention with a MitraClip significantly improved their survival, their symptoms, and keeping them out of the hospital. And so these types of clinical trials in their different results illustrate to us the very powerful effect of appropriate patient selection in learning which patient for which therapy.
Mm-hmm. And the question 3 is, could you share us your view about the future of the transcatheter view technology?
Sure, I thank you for that really important question, because for me, that is so much about what I do as a cardiologist in trying to advance the field, because I do believe that through less invasive approaches, we can truly help our patients with less morbidity and less complications. And I think so often we've seen that in other clinical trials that a transcatheter approach, due to its less invasive nature, is inherently safer, but perhaps not as efficacious in some of the previous studies. And therefore that improves, that efficacy improves as the physicians, the cardiologists and cardiac surgeons get better with applying the technology, as well as better at learning appropriate patient selection. Along with all this, that there are technological advances, and I'll give a great example of that. So one of the early transcatheter mitral valve repair technologies is the MitraClip. Well, the MitraClip evolved over time, and the most recent iteration of the MitraClip, the MitraClip G4, it's very exciting about some of the possibilities with it. And there also has another device, that is also a repair device called a Pascal by Edwards Lifesciences. Similarly, is introduced from a transvenous transeptal approach, and the early results from the non-randomized early feasibility study of the CLASP trial was quite encouraging, with a very high success rate in terms of reducing the MR to even 1+ or less, and also very high safety with that. So that has encouraged us so much. We're now in a randomized clinical trial comparing head-to-head MitraClip with the latest iteration versus the Pascal device. And this all speaks to, someday I think we will have a virtual armamentarium of different repair or even replacement technologies, such that we can, in a tailored approach, choose the right therapy for the patient in front of us, and it will be from a less invasive approach than what we've had in the past.
Mm-hmm. Thank you. That's the all question, and thank you for your participant. And I will send the articles to your notification.
Molly, one more thing before we close this up. I'd like to then talk, it wasn't on one of your questions, just talk about what I see for the Chinese community, because I think there's a lot of exciting stuff there. So can I just say something about that?
I think you can, no, my audio will cut, so you can say that by yourself. Don't tell me the audio, because I audio will cut.
Oh, you'll edit you mean you'll edit the audio?
Yeah. So,
Okay, yeah, so here, I'll just start talking. That's fine.
yeah.
So with all the transcatheter repair and replacement technologies that are being developed, one of the other exciting things for me is seeing so many of my colleagues, both in industry and among academic cardiologists and cardiac surgeons in China, developing similar fascinating repair and replacement technologies for the mitral and tricuspid valve. And I think the opportunity for me to work with my Chinese colleagues on developing the next generation of transcatheter therapies has been and will continue to be a very rewarding one. And I think it's a very bright future for the future Chinese patients who are struggling with mitral or tricuspid regurgitation, that we're going to have therapies in China for them. Thank you.
Can I ask your this how much you participate the CIT conference?
Oh yes, I've given some talks and sat on some panels. I've participated and really valued the contribution of, that I've been able to give and from my colleagues in the CIT conference. It's
Yeah. So
I know it's a virtual conference, but in this year, I think they've done a great job with adjusting to the needs of being a virtual conference.
So what do you think of the China's expert current interventional therapy technology?
So I think China, unfortunately, has lagged behind the US and the European Union in development of some of these interventional technologies for mitral and tricuspid valve disease. However, China is rapidly catching up, and I've seen a lot of very exciting designs that are truly innovative from many of my Chinese colleagues that I think is going to help not just China, but the rest of the world better treat, better care for our patients with valve disease.
Thank you very much.
You're welcome, Molly. Thanks for doing this interview.
Yeah. And I will send the link of the Facebook or the other website to you, and I will put the poster, your picture of the poster, and I will show you. It's so beautiful.
Okay, thank you very much, Molly. I appreciate it. I hope
I will send your email, so don't spend your time.
Okay, sounds
Thank
good.
you.
Thank you, Molly.
Thank you. Bye
Have a
bye.
good night.